Assalamu alaikum ji. So you have to be slightly brave जब rheumatologists call you to speak on their meeting. But as we were talking earlier, there is a great overlap और बहुत सारा synchrony है required between infectious diseases as a specialty and rheumatology as a specialty. Because ना सिर्फ के बहुत सारा overlap है but बहुत सारी coordination और cooperation की ज़रूरत पड़ती है. So first of all, I'll recognize my fellow Dr. Seemal Aslam, who was very kind to put together some slides for me that form the basis of what I was going to talk about today. And so she's not here in the room, but she was very kind to help me on this. Achha, so what we are going to talk about is biologics and rheumatology, which I'll talk very self-consciously about because I know the least about it and you know the most about it. So that is only to remind my own self कि ये क्या है. We'll talk about impact on host defense and which infections need screening. कहने को या करने को तो हर चीज़ को screen किया जा सकता है, but obviously you would be paralyzed if you tried to screen for every infection known to man. तो हम prioritize करते हैं और screening आमतौर पे उन चीज़ों के लिए की जाती है जो एक जिनका रिस्क हो, दो जिनका impact हो और तीन जिनके बारे में आप कुछ कर सकते हो. I often give the example of cervical cancer screening. Screen की जा सकती है, उसका impact है क्योंकि early screening का फ़र्क पड़ता है और आप कर सकते हैं. तो इधर भी हमने वही touchstone use करना है. When and how to screen के बारे में थोड़ी सी बात और some basic recommendations. थोड़ी सी history. So DMARDs that you're all so familiar with started getting used for Crohn's disease in 1998 to my information and for rheumatoid arthritis in the 1990s. अब आप आगे देखिए कि वहाँ वो इस्तेमाल होनी शुरू होती है और अगला ही लम्हे 1999 में same year or the year after perhaps you find that there is an excess of TB seen in these people. So this slide is really for me not for you guys और अपने आप के लिए याद दहानी, but for those that are perhaps non-rheumatologists like myself, there are these conventional synthetic disease modifying agents, so CS DMARDs, methotrexate, classic example. Then the biologic DMARDs, of course उसमें TNF inhibitors हैं, T cell co-stimulatory inhibitor, IL-6 inhibitor and anti-CD4, the classic Retux. और फिर targeted DMARDs, which are mostly synthetic, and things like JAK inhibitors, or this JAK for my non-rheumatologist friends is not JAK the Ripper, it is an enzyme जिसके ऊपर इसका नाम है, and of course steroids, which forms the backbone of many of rheumatologic interventions. अच्छा, very briefly before we screen ये तो देखेंगे करते क्या हैं. So TNF alpha has issues with bacterial infections, particularly M. avium and M. bovis. ये mycobacterium के रिश्तेदार cousins वगैरह हैं. And of course a lot of fungal infections because of the very fact that the pathophysiology is such that the risk of fungal infections is increased once you manipulate the TNF system. So Aspergillus histoplasma, ये तो ubiquitous है, हर जगह होते हैं. So is toxo, so is crypto, so is candida. Cocci जो है वो अक्सर औकात कुछ limited जगहों में होता है, अमेरिका के मगरबी हिस्से में, एरिज़ोना वगैरह, कैलिफोर्निया में. And so generally that's more a endemic mycosis. बाकी जो हैं वो तकरीबन हर जगह मिल जाते हैं. Histo भी थोड़ा सा endemic है, but कहते हैं कि you can find histo in other areas. Every now and then you see reports of histo from what you are not classically used to. Then of course IL-6 manipulation can causes differentiation of T and B cells and therefore has a wide-ranging impact because it affects both the humoral and cellular systems. And the protection is against almost the entire gamut of infections, from bacterial to atypical to pneumocystis to herpes. Acha, continuing on that thing, CD20 blocker, of course, B cell activation and consequently immunoglobulin formation. So very often you will see issues of organisms that require alive and healthy B cells that are forming immunoglobulins. And so therefore common association is with pneumocystis Hep B and C reactivation, classically, CMV, cryptococcosis. And for the Janus kinase, you have cellular immune responses mostly impacted, and that includes, classically, as we all know, viral infections and fungal infections, and of course tuberculosis as well. PCP should be in the fungus. By the way, I keep switching between PCP and the new name for it, the Girovechi, so please forgive me for that. Now, the European Alliance of Associations for Rheumatology, whom you all know, has a set of guidelines, and this is the crux of it. What they're saying is कि discuss ज़रूर कीजिए chronic opportunistic infections in anyone going on to DMARDs. Consider the possibility, pause for a moment, think कि इस शख्स को क्या हो सकता है और उसके क्या risks हैं. Do collaborate with other specialties, especially pulmonologists, gastroenterologists, and the rare ID docs you may find. Very important is that one needs to individualize. देखिए, guidelines are guidelines, but you need to be able to individualize your intervention. So consider and screen, and keep in mind habits, what vaccinations they've had or not, very often in our situation. Travel history, जैसे मैंने बताया कि कुछ जो माइकोसिस हैं आर वेरी एंडेमिक, कुछ दुनिया के एक हिस्से में होते हैं और दूसरी जगह नहीं होते. कोमॉर्बिडिटीज, स्पेशली डायबिटीज़, एंड प्रीवियस इन्फेक्शंस. बहुत सी इन्फेक्शंस ऐसी हैं जो एक दफ़ा हो जाएं तो वो तकरीबन जान नहीं छोड़ती. And so it is important to know if any history of those infections. So classical would be, for example, things that you need to worry about reactivation other than hepatitis. Things like fungal infections, cryptococcosis. You can also think about tuberculosis very clearly in that zone, in that context. But TB के लिए चूँकि specifically आपने screen करना, so more about that later. So previous infections की history is important to know. Then national guidelines for endemic issues. Now, I don't know what our endemic issues are. A lot of things are endemic here, and whether any of them have a direct impact on the management of rheumatologic conditions other than those that we are going to talk about, I'm not aware of. So the focus will be on tuberculosis and hepatitis, and a little word on invasive fungal infections. Okay. So TB ki risk assessment. Now this was a meta-analysis, 39 randomized trials across a long time period, 22 years, which is a large data set, 20,000 patients. And so the risk of biologics versus non-biologics, the odds ratio was 3.86. So in other words, if you were receiving biologics versus not, the odds of developing tuberculosis was 3.8 times. And if you compare TNF alpha versus placebo, that was 3.9 times. And look at this. Tufasitinib odds ratio is 7.39. So massive, odds, and of course the p-value is really small. So not only is the quantum of risk big, but the statistical odds of this odd being valid is very high. So this is something that we need to remember. Now, there's another way of looking at it, is to just follow a cohort. Natural history of disease को study कर लें, किसी हद तक ये यहाँ हुआ था. And this is 3,000 patients over 10 years. And they looked at latent TB infection using a quantiferin gold type test. And the incidence was 10%. The prevalence was 10%. And the incidence, interestingly, was about half a case per 1,000 person years of exposure. And very importantly, and please notice this, those that got a complete preventive treatment, there were no cases of active TB reactivation. In other words, बहुत सारी होगी या रिस्क होगा, लेकिन जब आप इलाज कर छोड़ेंगे तो नहीं होगा. So all the more reason. So ये जो मैंने शुरू में कहा था कि स्क्रीनिंग उन चीज़ों की करते हैं जहाँ आप कुछ कर सकें और उसका इम्पैक्ट हो, वो बहुत अहम है. तो यहाँ क्लियरली एक इम्पैक्ट है. There is something you can screen for. There is something that is common enough to be able to screen for. You need a method to screen for. And if you find it, so what? So there must be a so what. And the so what is you treat them. So जब ये तीन conditions पूरी हों तो you can actually screen. So TB fits those conditions. So the recommendation, of course, is screen for latent TB infection. I'll just spend a moment here on this latent business. Because I see younger people as well. And so the idea of TB infection versus TB disease. Look, almost all of us living in developing countries get exposed to TB. And many of us, by mid-age, by about age 50, about half of us have had exposure to tuberculosis. And that means that we've had TB infection. In other words, the TB bacillus gained access into our system, was stopped in its tracks by our immune system, and it created a memory. उसने उसकी शक्ल देख ली थी, अब आप उसको दोबारा दिखाएंगे, उसको याद आ जाएगा. उसकी शक्ल याद कराने के तरीके, the skin test and the newer test, the things like quantiferon. So we are screening for latent infection. Why? Because जब वो latent पड़ी है, तो once you mess with their immune system in one way or the other, it's going to wake up. And so it is recommended that for biologics and the targeted ones, you actually screen. Consider screening for the more conventional ones, and when you're using immunosuppressants, and certainly glucocorticoids. In fact, interestingly, out of the second bullet point, perhaps the most important risk stems from glucocorticoids, especially when used in higher doses. All international guidelines more or less recommend one sort of screening or evaluation or the other. So what do you do really? You can always consult, and my strong recommendation is, मैं 2 दिन पहले भी कहीं बात कर रहा था, and I said, look, if you are a practicing doctor today and you don't use some sort of online resource, something is wrong. Because I can tell you, I can't remember all this. And so we always have to refer to this. And it is so important to be able to check. So whether you use up-to-date, whether you just plain Google something, whether you have a textbook downloaded on your system, or whether you use something like the Sanford Guide for Infectious Diseases, kuch na kuch please istemal karen. Anyway, but just for reference and record. So what are the methods? You do a chest x-ray, you are looking for active infection. याद रखिएगा, once you find active infection, don't treat latent infection. उसको पूरे धड़ल्ले से, जोर से और पूरे 6 माह के लिए आपने पूरी दवाइयों के साथ 4 शुरू में और 2 बाद में उनका इलाज करना है. That also means that if you screen for latent infection, you must be looking to make sure that if that latent infection is present, that you are not missing an active infection. Because what could be more disastrous than treating an active case of tuberculosis half-heartedly? एक दवा या 2 दवा देके शायद आप मामला गड़बड़ करेंगे. So a chest X-ray is required when you do it. So there is a whole algorithm, and you look, chest X-ray positive है तो okay, of course active TB है, treat करें. It's negative, then you actually test for latent TB, and you can use a TST, which is a skin test, or you can use IGRA. Skin test किसी ने कराया आज तक? Show of hands. Yeah, so you look young, but शायद आपको कोई इत्तेफाक से मिल गया. Most of us who are slightly older have done these skin tests. Problem ये थी, what was the problem with the skin test? One, availability, which is obvious. Dirt cheap, but difficulty in finding it. The second problem was you had to inject it in a specific way. It had to be intradermal. The third problem was it had to be read 2 days later. And the last problem was reading was not so easy. You had to read it in 2 sort of axes and make sure कि duration है या नहीं. ये सारी बहस और मुबाहिसा ख़त्म हो गया with the arrival of these more sophisticated lab version of the TB scan test, which were the interferon gamma release assays, the IGRA test. The problem is of course they are more expensive. Nevertheless, they are quite common today. So once you find a true positive, a real positive evidence of latent infection, they need to go on treatment. Half the challenge these days is you can't find these standalone TB drugs. So the classic way of doing this was isoniazid for 9 months. वो अकेली नहीं मिले तो फिर then you can use a combination of rifampin INH for a shorter duration, but वो आजकल मिल नहीं रही. So sometimes you are actually stuck with using rifampin INH and the whole full TB regimen for 3 months just to treat latent TB infection. So that's another practical problem, and this is how we're trying to solve it. हाँ, एक चीज़ आपको बताऊँ, rifampin pyrazinamide ना use कीजिएगा. उसकी वजह यह है that there was a trial for latent TB infection for rifampin pyrazinamide for 3 months, and there was increased mortality in it, and which is odd, क्योंकि हम classic TB treatment में, disease में हम actually treat करते हैं उन दवाइयों के साथ, but for some strange reason, and we can go into why that was if you're really interested, but so in other words, don't use rifampin pyrazinamide. अगर use करना है तो isoniazid alone या rifampin with INH. There are some other protocols as well that exist, and if you really get stuck, then maybe consult someone. So switching gears, TB तो हमारे यहाँ हमारी तकरीबन एक तरह की national disease है. दूसरी national disease जो है वो हमारी hepatitis है. And so both Hep B and C can get reactivated. And so reactivation का ज़्यादा मसला जो है वो because B का comprehensive, complete and final इलाज उतना ज़बरदस्त नहीं मौजूद जितना hepatitis C के लिए है. So therefore the focus will be on Hep B. So they did a meta-analysis, people with HIV and psoriasis, 14 articles, cohort studies, case series, over 1,000 patients. And all of these, so Hep B reactivation was significant, Hep C की और HIV की, in तीनों cohorts में you saw significant reactivation of hepatitis B. So therefore the recommendation is screen prior to starting biologic agents. For Hep B, reactivation means पहले थोड़ी थी और अब ज़्यादा हो गई, या पहले थी ही नहीं, ये जिसका पता ही नहीं था, in other words गायब हो चुकी थी और reappear कर गई, फिर से नमूदार हो गई. So पहले एक lower level पे थी and it goes more than a log fold of copies per ml, in other words बढ़ गई, या आपने पहले ट्रीट कर दी थी, डिसअपियर कर गया था और रीअपियर कर गया, यानी दोबारा से नमूदार हो गया, HBV DNA. And the risks of course are prior infection, hepatic persistence in other words, and of course very predictably active infection. So ये दो सूरत हाल हैं जिनके बारे में हम वरी करते हैं. अब recommendations क्या हैं for RA? The ACR says no definitive clinical guidelines, but it does emphasize monitoring disease in already diagnosed patients. So sort of a conditional recommendation. So EULAR and CRA, the Canadian one, they want screening for all, as does the Society for Liver Diseases in the US and the CDC. अच्छा करना क्या है? Use क्या करनी है? This gets a little bit confusing, and I'll show you in a subsequent slide what goes wrong. Hep B surface antigen, anti-core and anti-HBS. होता क्या है कि and so what you're supposed to do is you do a surface antigen, they're positive, they're carriers, you prophylax those with BMARDs. End of story. जो surface antigen negative हैं, it gets a little complicated there. And so what you end up doing is that you do a core. And if the core is positive, this means that the infection had resolved, and you do baseline LFTs and HBV, and then every 3 to 6 months. If they turn positive, in other words, ये एक preemptive सी strategy है, you say, okay, fine, we will serially screen these people, and if they turn positive, then you treat with antivirals, and if they remain negative, then you're good. And of course, if they are core negative, then it's the usual follow-up. I've put up an algorithm which you can always look up. It's easily Googleable and available everywhere. Look it up, and if you run into any trouble, you can always consult it. The question is, do we do it well? ये तो है गुफ्तगू जो होना चाहिए, but do we actually do it well? And this is a publication which is interesting. This is relatively recent, a year ago. So 913 subjects initiating TOSI and 630 subjects initiating TOF. And the results of the screening, a third were done right, a third inappropriately. उन्होंने E antigen करा दिया, which is infectivity, not anything else. या DNA करा दिया in non-infected person, यानी the opposite mistake, a more sophisticated test where none was required. And IgM करा दिया core के लिए, which again is not helpful. So the wrong test. And in 2/3, and then, sorry, not 2/3, the rest third is, partially correct. कुछ ठीक किया, कुछ गलत किया. All I wanted to show here is that despite all these guidelines, it is very easy to make a mistake. So always I go back to that. Use your booty. Put that image on your phone and consult it, and you won't go wrong. Or better still, consult a live resource that is updated with time. ये एक और meta-analysis है, 30 articles with 23,000 patients. 10 of 30 studies में कोई reactivation नहीं थी, but in the remaining you had reactivation. And what was the risk of reactivation? Hep B की बात कर रहे हैं. Higher prevalence कहाँ थी? In older studies. Why would that be? Because the field wasn't as mature. Number 2, there was greater prevalence of Hep B. Number 3, a smaller proportion of people were appropriately suppressed. It was also higher in retrospective studies and higher in Italy. Lower preference was, of course, cases treated with certain drugs, and I've listed them all up. So, and the lowest prevalence, of course, was with rheumatoid arthritis. So I've lost the image here, so I'll look up here. Okay. Hep C, as I mentioned, is somewhat of a lesser problem now because of better treatment and the fact that you can get rid of it completely. But you must screen for it before the start of treatment, especially in those people who have a history of IV drug use. Please ask. Itni kam nahi hai hamare yahan. It's not so unheard of. So please ask. Dusra, if they have abnormal liver function tests. I think that's a giveaway, and it's an obvious one, so I'm sure all of you do it. And if you have Hep C that is positive, then you need to screen with a PCR and actually treat it. So PCP और PJP ये वो जरासीम है जो अपना नाम और अपना हल्का तब्दील करता रहता है. There was a time when it was during my training years this was considered a protozoan, and then इसका हल्का तब्दील उसी वक्त हो रहा था and became a fungus, and lately पिछले कोई 7-8-10 साल में इसका नाम भी तब्दील हो गया. So the data for its prevalence or its reactivation is much more solid out of use of high dose steroids. And that is its classical original presentation. Long before HIV, you saw it in people with cancer or with steroids. And the recommendation is to screen it or to look for it when you have used high dose steroids or more than 15 mg per kg, especially for more than 2 weeks. What do you use? Trimethoprim sulfa, dirt cheap, easy to get, other than when it's IV. Just today, somebody showed me an X-ray which in an HIV patient, which is out of the book pneumocystis. Unfortunately, there's no IV IV cotrimox in this country. So you end up giving a lot of oral and hope that it gets absorbed. Anyway, but we are talking about prophylaxis. So you can use a double strength tablet thrice a week. You can use a single strength tablet every day, and perhaps even something less. But a single strength every day usually is a good bargain because it's easy to remember. But some people want to have it thrice a week, which is also fine. The alternatives are not available. Atovaquone, Dapsone is available. You don't have nebulized pentamidine. And the only reason you need to use Dapsone, याद रखिएगा कि pneumocystis में there is one which is grade 1, सबसे बेहतरीन ये क्या कहते हैं, 1 number is trimethoprim sulfa. Everything else is 2 number. So if you don't use trimethoprim sulfa, it should only be because you truly have a severe allergy or you can't use it. Otherwise, please, there is no other choice. Nebulized pentamidine भी यहाँ तो मैंने नहीं देखी कभी, किसी ने इस्तेमाल किया तो मुझे बता दें. I've never been able to find it or use it. VZV, varicella zoster virus. Now here the issue is that you've got 2 vaccines, a live vaccine and a non-live vaccine. And the BSR, जो आप लोगों की ही society है in Britain, conditionally recommends that patients with RA and psoriatic arthritis get live HZ 2 weeks prior to start of DMRD, especially if you're over the age of 50. The issue here is that a lot of people have chickenpox in childhood. The virus goes to sleep, to hibernate, and wakes up typically when we are over the age of 50, or we have had steroids, or we are weakened, or we have a weakened immune system for one reason or the other. So it is in that circumstance that we want to use it. EULAR, of course, says that the live vaccine should be administered 4 weeks prior to at least BMARDS and TOFA. Screening के लिए कोई clear-cut guideline नहीं है, and it's somewhat understandable because the field is more complex. EULAR suggests that you guide patients about post-exposure prophylaxis especially. So somebody is on a disease-modifying agent, and they get exposed, to please educate them कि आपने हमें बताना है, so we can try to give you post-exposure prophylaxis, especially if they are not vaccinated and or their vaccination status is unknown. यहाँ एक और मसला आ जाता है. वो मसला ये है कि अगर आपने post-exposure prophylaxis करना है, तो the classic post-exposure prophylaxis was VZIG, which is the varicella zoster immune globulin, a specific targeted immune globulin. So ask me if it's available. No. It used to be. Funnily, 20 years ago, 15 years ago, a lot of these things were available, but they are not, primarily because of pricing and other reasons. So VZIG kuch arsa to globally napaid ho gaya tha. Now it is available in the rest of the world and in many parts of the world, but VZIG yahan nahi milta. Sometimes people use pooled immunoglobulin in the hope कि उस pool के अंदर कुछ ना कुछ immunity मौजूद होगी. So that is something that you can consider. HIV. Screen all for anti-HIV. That's a given. But I can tell you that BMARDs have been successfully used. Mostly case reports, you do not have systematic data too much. Retrospective series एक हमें मिली 17 मरीजों की, जिसमें TNF alpha use हुई. 15 on ART had no issues. Only one had to stop biologics due to a dropping CD4 count. So generally, if you find HIV, you can go ahead with your rheumatology business. Perhaps flag this to the patient, of course, and to their caregiver in HIV कि भाई हम ये कर रहे हैं. It's very little to say about COVID, or I should say there's a lot to say about COVID, but there's a plethora of information. It all goes in the same direction. Generally, prevalence of SARS-CoV-2 infection in patients with rheumatologic and musculoskeletal diseases was higher. In other words, those with these diseases, you saw more of COVID in them, and the odds were also somewhat higher of dying. Vaccination seems to work. Interestingly, if you measure vaccine immune responses after the first dose, you add a second dose, it goes up. T-cell response rates are much better. Overall, if you try to measure responsiveness, you will not find really great evidence, but the effectiveness is still there. So bottom line is, whether you use messenger RNA or the AstraZeneca or the other vector vaccines, including the CoronaVac, you're good. So as I mentioned, seroconversion आपको इतनी अच्छी नहीं मिलती, but T-cell response are a little bit better, and you can see there is a difference between rheumatic patients and the healthy populations, but nevertheless there is enough protection against severe disease that it makes great sense to vaccinate them. Fungal infections. Now here the data gets scantier because there is not as much systematic collection of it, but nevertheless the risk of invasion is there. There is high risk, especially those on steroids and other DMARDs. And there are plenty of studies that propose screening for histo and cocci in high-risk areas, which usually means parts of the United States. I don't know what to tell you about Pakistan. Histo में एक study हुई हुई है in the 60s in blanking चकवाल के पास या कहीं. Anyway, so they had done serologic surveys and they found that there was histo, but I have actually never seen histo here. Whether it gets lost in a lot of TB, I don't know. So I would say that in our context, there is no central guideline for prophylaxing for histo in Pakistan. So key takeaways, I hope I haven't gone too much over time, is that DMARDs always pose a risk of infection. Always screen for TB for sure, both for active and latent. For HIV, Hep B and Hep C. Give pneumocystis prophylaxis in selected patients, especially those on steroids. And have a low threshold for suspecting or thinking about invasive fungal infections. And post-exposure prophylaxis, yes, but then what to do? One hint I gave you is just using pooled gamma globulin, but consult someone in that scenario. Much better to have a little bit advice on that. And of course, vaccinate patients if they are not vaccinated, especially for COVID, and or other things, including flu, seasonal flu vaccines, including conjugate vaccines for pneumonia, easily available. And if there is any question, always ask. Thank you. I've run through this awfully complex topic, but hopefully I've made some sense. Thank you very much.